I think we should get started. I'll take my mask off because nobody is very close to me. Um, I am Debashish, as Ebun just mentioned. I'm one of the kidney doctors here at St. George's Hospital in UK. But it is a real pleasure introducing both John Eastwood and Professor Bang Boye from Lagos in Nigeria. Now, this is very appropriate because, as you know, last week we had the grand round because of the World Kidney Day. So this is very close to that. Last week, we discussed about delivery of kidney care in a large country like India. And this week, we're going to talk about Nigeria. To introduce Professor Bang Boye, he's a really stellar nephrologist from Nigeria. He's the past president of the National Society in Nigeria, and he's the clinical director in his hospital. As you can see that he is in his clinic now with a patient chair behind him. So he's going to let us inform us about the care, kidney care in Nigeria. But before that, it's also a pleasure to introduce John Eastwood, one of my colleagues who is now retired and has had a lot to do with international nephrology, particularly with his contacts with the African continent, including Kumasi and in Ghana. So first of all, John will speak, and then we will introduce Professor Bang Boye once again. John?
Thank you very much, Debu. It really is a great pleasure to welcome Ebun Bamboye, because we go back to about 2001, which is when the ISN, for the first time, we had written to the ISN to say, look, have you ever been here? And they said, no, never been to West Africa. And it was the first visit ever. And the team, including Sarah Naika and John Dirks and myself, we first of all went to Ghana and then to Nigeria, which was the main destination. The population of Nigeria, as most people know, it was 180 million last time I heard, but it's always been about 50% of the whole of West Africa by population. So it is the place for a visiting team to go. What interested me, that even at that time, Ebun was talking about transplantation, which was almost non-existent in most of Africa, and especially West Africa. And at St. Nicholas Hospital, to my amazement, he was talking about starting a program. Now, of course, we met on many occasions afterwards because Ebun would come to the annual CMEs that were funded actually initially by the International Society of Nephrology. It was the way they got Ghanaian nephrology started, by these annual CMEs, and then the local country takes on the funding and organization thereafter. But even at that time, when dialysis was all the rage, but it was totally unaffordable, Ebun was ploughing a lone furrow. I mean, there may have been one or two others, but mainly Ebun in Lagos was talking about transplant programs and the developments that would follow those. I will be fascinated to hear what's happened since. I don't think we've met for about 10 years, have we, Ebun? Something like that. And I'll be very interested to hear the topic of the talk, the development, or it's actually the state of nephrology in Nigeria. And I'll be most interested to hear how things have progressed and how St. Nicholas is doing in the transplant world. So thank you very much, Ebun, for coming to see us. We welcome you from St. George's with all good wishes. So thank you.
Thank you.
Thank you very much, John. Ebun, do you want to share your slide?
Will do.
Thank you. Great.
Would you like me to start?
Yes, please.
Okay. So, well, good afternoon here. I presume it's just a little after 12 there in the UK as well. And thank you very much, Professor Debashish Banerjee, for inviting me. Thanks, John, for your very kind words, and also thanks to Joyce for making this connection. Over the next couple of minutes, what I will try to do is to give you a view of what the practice of nephrology is in various parts of Africa, but specifically in Nigeria. And I'm certain that after I might have finished, one key objective would be for you all to appreciate what you have over there in the UK that I'm certain some of you might be complaining about. I'll get you to appreciate it a lot more. I have no disclosures, and like I said, I want to thank the St. George's team for inviting me. I bring you greetings from Africa. Many may not realize that Africa is the second largest continent and has about 17% of the population of the whole world. And in that map of Africa, you can actually fit in the whole of the United States, the whole of China, the whole of India, and the whole of Europe. That's how huge the size of Africa is. I also bring you greetings from Nigeria, where I am based. It's, as John said, the largest and most populous country in West Africa, and we generally are regarded as the happiest people in the world. Nigeria is a federal republic. We've had a democracy for well over 30 years now, which consists of 36 states. We used to be a colony of the United Kingdom of Britain, and we had our independence exactly about 60 years ago. Lagos, where I'm based, is the financial capital, and you see the importance of that as the talk goes along. Within that country, we have about 500 distinct languages with 250 different ethnicities. Our language, however, is English. We're about 4 times the size of the UK in land mass, and we're about 4 times the population of UK, with quite an urban population and a population growth rate of about 2.58%. It's generally a very young population, and our median age is about 18 years, and we are the strongest economy in the whole of Africa. Like I said, I'm based in Lagos, and that's a view of what Lagos is like. And I certainly would invite you to come down. I know John has been a couple of times. I work at St. Nicholas Hospital, which has the reputation of pioneering quite a bit of renal care in Nigeria. I joined them in 1994, so we started off dialysis and pioneered bicarbonate dialysis. We pioneered kidney transplantation actually about 21 years ago now. And so far we've done close to about 500 kidney transplants. Nigeria's population has grown quite rapidly in the last couple of years, such that we're now the 7th most populous country in the world, coming after China, India, US, Indonesia, Brazil, Pakistan. And it's estimated that come 2050, we probably will be the 3rd most populous country in the world after China and India, if the trajectory we're facing now continues. Like I said, we're a very young population with a median age of about 18.1 years, strongest economy in Africa. After us is South Africa and then Egypt. And we have quite a number of very wealthy people in the country. But that's not the story. I think there are quite a few people who are billionaires. But we also have the largest extreme poverty population in the world. This study done in just about 2 years ago showed that Nigeria probably has, because of our population size and the number of rather poor people living below the poverty line, probably the largest population of poor people in the world. The distribution of that poverty is uneven, and you get to see that when it comes to the quality of renal care in different parts of the country. You find that there's a very large proportion of that poverty in the northern part of the country. And this also reflects in the quality of healthcare and the outcomes that we see. And you find that the worst capacities and outcomes are seen in the northern part of the country and the best in the southwestern part of the country, which is where I am based. So whether you're looking at skilled birth attendants, fully immunized children, or under 5 mortality, you'll find that the worst statistics are always in the northern part of the country. Most of the funding of healthcare in Nigeria is out of pocket, unlike in UK where you have the NHIS or you have the NHS. 70% of people actually have to pay for whatever care they receive out of pocket. We don't spend enough on healthcare. Health expenditure as a percentage of GDP is only about 3.9%. And compare that with what obtains in the UK, which is 9%, just a little under 10%. And I must commend your NHS, regardless of what you and a lot of professionals say about it. I still feel it's probably the best method of providing healthcare compared with any of the other systems anywhere else in the world. So consequent on that, what you find is that the health sector is underfunded. There aren't enough doctors, partly because quite a number of those doctors have emigrated to other countries in the world. And I would give you some statistics as regards specifically the nephrology aspect of our doctors. Healthcare as percentage of GDP is only about 0.69%. And like I said before, the budget has only about 3.9% of it spent on health. We do have our own national health insurance scheme, but the total number of people registered under that out of a population of 209 million is only 5 million, which represents only about 2.5% of the total population of the country. So almost everybody else is paying out of pocket. Going on to specifically about renal care. Generally in sub-Saharan Africa, this picture is replicated and in many instances even worse off than what I've described for Nigeria. So what you find is that there's a startling gap between the estimated incidence of end-stage renal disease due to glomerulonephritis, diabetes, and hypertension, and the number of people that are actually on renal replacement therapy. And this slide actually shows a comparison with other regions of the world. Whilst in Japan and the US, you're looking at sometimes about 200 per million population. Most countries in Africa have less than 50 per million population actually on regular renal replacement therapy. And this is not because CKD is not uncommon. In fact, if anything, we believe that the prevalence of CKD is higher than in other regions of the world. This study done by Stanifer and Saralanika, which John mentioned earlier, looked at several studies looking at both at CKD prevalence in different parts of the continent. And out of the 21 medium quality and high quality studies that were reviewed, the prevalence of CKD was established to be about 14% in the whole continent as a whole. But in Nigeria, we've done several studies. These are community-based studies done by different people. And this done by Olasia and her group estimated about 11.4%, while Inwanko and his group somewhere up in the north got a prevalence of about almost 18%. So it varies between that 11% and 18%. And if we compare Nigeria with other countries in Africa, other than South Africa, which economically and health-wise is much better developed, and they have well over about 5,500 patients on regular dialysis. And Sudan, Nigeria comes third, with the total number is just about 2,500. So even though 16% of the world live in sub-Saharan Africa, we only represent about 1% of the total number of people on dialysis and other forms of renal replacement therapy in the world. What do we have? We have people who visit various quacks and herbalists. This is Dr. Juma, who can treat and solve many problems such as the same potion that he gives for swollen body, which I presume would be kidney failure. He gives for all manner of illnesses, including bad luck. And some of the hospitals that you might see in some parts of the country, and even the so-called established ones, you now have an Ebenezer Dental Clinic who looks after menstrual pain, fibroid, stomachache, cough, and chest pain. We know that chronic kidney disease is increasing widely. We know there's a lot of diabetes and hypertension responsible for this, but we'll talk about what the situation is in Africa. But we also recognize that worldwide it's been established that being from the continent of Africa seems to predispose you to kidney failure more likely than any other ethnic group. So be it in the US, where the prevalence of chronic kidney disease amongst the blacks is about 4 times the prevalence of those in the UK, or in the UK, where it's amongst the white population and amongst the African Caribbean population, you'll find that easily the prevalence is much higher amongst those of African origin. There's several reasons that have been adduced for this. Of course, poverty, ignorance, illiteracy, poor access to healthcare. But I think more recently, a lot of credence is being paid to the possibility of apolipoprotein 1 gene being responsible for this. And several studies have been done. This was a gene, as you might all be aware, which was supposed to be protective from trypanosomiasis and consequently was quite prevalent in the west coast of Africa. And the consequence of that is that you now find that the highest prevalence of the apolipoprotein 1 gene is in West Africa, whilst in Europe it's just about 0% or non-existent. In African Americans, about 10 to 15%. In west coast of Africa, it's almost 50% of individuals have either the G1, G2, G1, G1 or G2, G2 variant of the apolipoprotein 1 gene. And so looking at the prevalence and burden of chronic kidney disease in different parts of Africa, whilst in the northern part of the continent, where you have mainly the Maghreb and Arab population, you have it at almost 4%. You find 12% in the south, 16% in the central part of the country, 11% in the east, and the highest prevalence is in that part of the continent where this apolipoprotein 1 gene predominates. The causes of chronic kidney disease in Africa are slightly different from what you find in the developed or the Western world. And we find that chronic glomerulonephritis clearly is the commonest cause, followed by hypertension. And diabetes actually comes third. Estimating a population, an incidence of about 100 per million population of individuals ending up in end-stage renal disease in Nigeria. And with a population of over 200 million, we should have about 20,000 individuals yearly requiring renal replacement therapy. And if you actually calculate the prevalence, which should be at 465 per million population, this is the number that you get. But the total number of people on dialysis, various forms of dialysis in Nigeria, are actually less than 5,000. The causes, like I said, are predominantly hypertension, chronic glomerulonephritis, with diabetes third. But then we have a lot of other causes. HIV is quite prevalent. I think the HIV prevalence in Nigeria is about 4% now. And of course, all the other causes that you commonly see, inclusive of also sickle cell disease. And the carriage of the gene in Nigeria is about 21% of the population, with about 1% of them with the homozygous condition at birth. Looking at statistics from the hospital here, like I said, the commonest cause is chronic glomerulonephritis, followed by hypertension. There are a number that presents so late that you're not able to determine the cause, but diabetes is clearly third. And I think this is probably reversed amongst your own patients, where diabetes will probably be the commonest cause of chronic kidney disease that you see. So many of these people, despite ending up in end-stage renal disease don't get any form of definitive therapy other than conservative therapy. So we have several challenges facing renal care in Nigeria. So even though it's a major problem, we don't have the numbers of personnel, be it doctors, nephrologists, nurses, or technicians to deal with it. There are not enough dialysis units. Even the ones that exist are only in the urban areas and not equally distributed, as you'll see. And even the ones that exist are small, they're poorly run, and sometimes not very well maintained. So it's not uncommon that over 80% of the patients are first seen at the point where they require dialysis. So we never catch them in stages 1 to 4. So at the point where they end up or present in acute pulmonary edema that we often see them. And not unexpectedly, the outcomes are also not good, particularly in the public sector, in the hospital, in the country. And this is one example. This is from one of the larger teaching hospitals somewhere in the southwestern part of the country, where they looked at 1,200 patients that they had seen over about 12, 20 years. They found that about 10% of medical admissions were secondary to end-stage kidney disease. They reviewed 760 of those patients. There's always a male preponderance. Hemodialysis was offered to 556 of those 760. And at the end of 3 months, only 38 of those were alive. They offered CAPD in 9, and within 6 months, all 9 were also diseased, and 7 were able to avail themselves of a transplant in that particular teaching hospital. And majority of them actually had one form of conservative management, and almost 90% of those who were restricted to conservative management because they couldn't afford the cost of care ended up, succumbing to the illness within 2 weeks. So overall, 87% died within 1 month. So number of nephrologists in Africa compared to other parts of the world, whilst in Europe, I know UK is out of Europe now. This was about 31 per million population. It's compared to 1 per million population. In sub-Saharan Africa, Nigeria probably has the largest number of trained nephrologists, but you'll find that compared to our population, it still is less than 1 per million population. We did this survey about 3 months ago, and we found that as at current counts, we have 230 trained nephrologists. 173 of those are male and 54 are female. But if you look at what obtains in the United States of America, where doing a similar survey at this time, we looked at the numbers of African trained nephrologists now practicing and we found that Nigeria alone has the highest number, which is just about half the number that we currently have practicing in the country. And in the UK, not as many, but still quite a number. And we have 7 trained nephrologists practicing in the UK. 4 of them male, I think 3 were female. Majority of them, in the ages of about 40 to about 60 years. So you find that if we look at the numbers of nephrologists trained in Nigeria that are practicing currently in the UK, the US, in the Middle East, Canada, and Australia, we probably have a larger number practicing outside than they are practicing in. Dialysis activity in Nigeria, we've had PD since 1966, but mainly now because of the costs of importing the fluids are not available or manufactured locally. It's restricted to mainly pediatrics and then intermittent peritoneal dialysis in acute settings, but not CAPD. We've had hemodialysis since 1981. To see now there are over 180 dialysis units all around the country. We pioneered renal transplants at St. Nicholas in March, the year 2000. And currently, like I said, there are over 230 trained and actively practicing nephrologists all over Nigeria. Just as the earlier map I showed, majority of those units are located in the southern part of the country. And if you see southwest, south, all are responsible for many more than, the geopolitical zones in the northern part of the country, particularly in the administrative capital, Abuja, and the financial capital, which is Lagos. Specifically looking at transplants worldwide, you find that, compared with the more developed parts of the world, the numbers of transplantations that are being done in Africa are a fraction of what is available. And in terms of where that is being done, South Africa is the clear leader. They currently do about 300 transplants per year. Sudan also has a very strong renal program, and they do about a little under 200 transplants yearly. We've done transplants in Nigeria since the year 2000, and currently there are 15 units, and we currently do between 150 and 200 transplants per year. The cost is indicated, and this just graphically looks at the different parts of the continent, sub-Saharan Africa, where transplantation is currently carried out. So far in Nigeria, about a little under 1,000 transplants have been done. All have been live. We don't have a diseased donor transplant yet. The donor nephrectomies are done a mixture of open and laparoscopic. There's some concern about commercial kidney donations, but mainly for those who travel outside the country. But most public-based programs are small and actually carry out limited numbers. And these are where the different transplant units are in different parts of Nigeria. So there's only one unit in each of the zones in the north, whilst in the southwest part of the country, we actually have the highest numbers. So whilst in the southwest, we have 6 units able to carry out, or who have at some time in the past carried out transplants. You only have 1 in all the other geopolitical zones, aside from Lagos and Abuja, that each have 3 units. And these are the numbers that have been done by the different units. We find that majority of them do no more than 1 or 2 transplants in the last 10, 15 years. Looking at the last 3 years, these are the numbers that have been done in the different units and more so aggregated around the country. So we're doing between about 100 and about 150 and about 200 transplants in every year now. The challenges of the typical public health institution in Nigeria, they generally tend to be overstaffed, poor maintenance culture, poor work ethics, and there's the attitude to patients, lack of empathy is of concern. There's a lot of interdisciplinary rivalry between various professions, and consequent on this, strikes and work to rule are quite common. In terms of the causes of kidney failure amongst patients that have had transplants, it mirrors what we said earlier, mainly hypertension and glomerulonephritis with diabetes. There are various challenges to transplantation in sub-Saharan Africa. I probably wouldn't go through most of this. But the main problems are concerns about costs, given that the patients actually have to pay for these transplants out of pocket or after they may have solicited for funds, from the public. The low literacy and education also further compounds the problem, and as such, compliance and adherence are thus major problems to, long-term favorable outcomes for the transplants. And of course, there are high risks of opportunistic infection, but there's some advantages. Our patients generally are young. You find that the mean age for our population of patients on dialysis is about 40 years, compared to what you have in the UK, where I think it's generally trending towards almost like a geriatric population that you have. I think that has a lot to do with the young age of the population itself, with a median age of 18, and the causes of kidney failure that we see. We see less of diabetes. We also see less females. There are not that many pediatric patients, and all the transplants we've done are living donor for now. And generally, those patients have not been able to afford to be on dialysis for long prior to the transplant, all of which could give some advantages to positive outcomes. So far, there are not many retransplants, and we see less of diabetes. Now, very quickly, what has been our experience at St. Nicholas Hospital? We see an average of 150 new patients every single year, roughly about 10 new patients coming every month. These are the number of dialysis sessions we carry out. Like I said, there's predominantly a youngish population, and we find that the peak age there for this 1 year was that. And the oldest was 90, the youngest was 14. The mean age, like I said, is about 47.6 years. The peak age in females is slightly younger, mainly because a lot of this is due to pregnancy-related hypertension that has been poorly managed. More male than female. And in terms of the prevalence of viral infections, you find that 3% of them are HCV positive, 2% are hepatitis B positive, and about 4% of them at screening prior to commencing dialysis are HIV positive. In terms of frequency of dialysis, and this, I must warn that the patients we see in St. Nicholas are quite different from the patients that you see in many of the other public hospitals. Many of these are relatively privileged and have sponsors that are responsible for covering the cost of their dialysis. And regardless of that, you find that most of them are on twice weekly dialysis. Only about 10% of them are on thrice weekly, and some are even on just once a week. We generally tend to make sure we create access, so very few have AV fistulae, about 10%, mainly because most of our own patients, we try to push and get them to do a transplant as soon as possible. IJ catheter in about almost 90%, and very few of them actually have femorals at their source of entry of vascular access. The length of time of dialysis in 2019, we looked at the vintage patients that we had, and we actually have one that's been on dialysis with us for over 20 years. He's a Jehovah's Witness, and he's refused to have a transplant. He has an AV fistula, and he continues to do well on dialysis. So in that year, we managed 152. The average age was that. And in that 1 year, mortality, as opposed to almost 90% that you saw in the public hospital, was just 5% in that 1 year. And the average length of time on dialysis for all patients is about 10 months. And we tend to be successful in correcting their hemoglobin. We also have the capacity to do plasmapheresis, which, as you know, is important. We've had several relationships with different hospitals over the years at St. Nicholas. We started off with the Royal Free. We stayed on with Hammersmith for quite a while. We've had a relationship with the University of Birmingham, Transplant Links. And more recently, we've also associated with hospitals in India and the United States of America. We did the first transplant 21 years ago, majority of them male, and most of them genetically related. The youngest we've done has been 13. The oldest has been 67. And these are the numbers that we've done over the years. And more recently, we've done many more. Of course, 2020 being the annus horribilis that it was, we saw a dip in numbers. But other than that, we've consistently been increasing. I had projected this year to do, many, many more in the hospital. We've had our transplant surgeons come from different parts. Ayo Shonibare is our local surgeon. We've had some coming from the UK, and I'm sure most will know Professor Hakim Nadi. Professor Gordon Williams actually helped with starting off our program 21 years ago. He used to be at the Hammersmith. And then Andrew Reddy, who came from the University of Birmingham. The age range of our patients, more male than female. And the etiology of kidney failure amongst our transplant patients over the years, mainly hypertension and chronic glomerulonephritis. The donors have ranged from 18 to 70 years, generally slightly younger than the recipients, more males than females, where the patients have come from, and the relationships between the donor and the recipients. More recently, we've trended towards doing the donor nephrectomies laparoscopically, and this is full laparoscopic or sometimes hand assisted. This was what Andrew Reddy actually came to demonstrate when he came to us about a little over 10 years ago now. Our patients, even though we do the transplant, still many go outside the country, particularly to India. We've had a few that have had their transplants in the UK and the US. And we find that often the donors that we've rejected because they're non-altruistic end up going particularly to Pakistan, some to India, and end up with the transplant using the same patients. And sometimes the outcomes are not quite as good as they otherwise would have been. This is one such example who ended up in Pakistan, had a hyperacute rejection, and was just sent back to the country with a few ampoules of methylpred. We have a Nigerian Health Act, which now enables us to do disease donor transplants, and that is the next thing that we're looking at, hoping that we can then widen the scope of transplantation. The challenge of kidney transplants in Africa is a significant and recurring barrier to transplantation in Africa is high cost. So, and not just the cost of the transplantation, the cost of follow-up care, and the cost of the maintenance immunosuppression that follows. So we need to actually address this. And the positive environment will change this scenario. We'll have to include a way that government can be part of funding to ensure that it becomes open to many more people. What to do? We have to increase the number of dialysis units, make sure they're equitably distributed, increase the personnel to be able to, like making sure that we train, change attitudes, and improve the equipment, and ensure that we transfer suitable patients onto transplantation. We need to better manage them in terms of their anemia, nutrition, ensure proper access, and vaccinate as appropriate. And transition to renal transplantation as soon as possible, which is what we try to do at St. Nicholas Hospital. And then collaborate. I mean, that has been the success of our own program. Over the years, we've collaborated with different units that we recognize have much better experience. But there's also the need for us to have a registry so that we actually have more precise statistics as to what is the scenario of chronic kidney disease in the country. Other measures I've listed, but most importantly is to also look at the diseased donor program. We now have the legislation. We have to increase public awareness. We have to ensure functional and cooperate with different ICUs and, public enlightenment about the opt-in and opt-out, which I'm now informed that the UK has also progressed to. And then make sure that a lot of the requirements which we now still have to send out of the country, like the typing and cross-match, and sometimes more precise histology for renal biopsy specimens are more available locally. This is a picture of this was a young man who donated to his younger brother, and this is Dr. Shonibare, who is our local transplant surgeon. And my favorite pair, this was a gentleman who donated a kidney to his wife, and this was done 24th of January in the year 2001, so exactly 20 years ago, and she's still doing very well. I think I'll stop here, and I'll be willing to listen to any questions and comments that you have. Thank you.
Thank you very much, Professor Bangboy. I'll take my mask off for a while. I have several questions. A very clear and very good presentation, which gives us a very good idea of what's going on in Africa, particularly Sub-Saharan Africa and Nigeria. And thanks also for sharing the wonderful work that you're doing at St. Nicholas Hospital, which seems to be amazing. Can I start off with a couple of questions? I can't see any hands right now, so I will start off. So the first question regarding government funding, possibly in a more local fashion for kidney transplantation. And I tell you why I'm asking this question. It seems that the South, particularly Southwest, is where a lot of healthcare, good healthcare is happening. So is it that the government funding is always federal for health, or can local governments can also fund, for example, the transplantation in the local area, because that might bring the cost down, increase collaboration, set up donor sharing mechanisms, etc. So can that actually happen? Healthcare funded more locally?
Well, the answer to that, the easy answer is yes. But the way the health funding is structured in Nigeria, we have primary, secondary, and tertiary. The primary, which looks after primary health care, is supposed to be under the supervision of the local governments. Secondary care is supposed to be under the state governments. And tertiary care, ideally, should be under the federal government.
Right.
So you'll find that most of the things that you'll do in a tertiary hospital, and most of these tertiary hospitals are supposed to be federal government funded. But the reality is that quite a few state governments also would fund some tertiary care. But as you'll see from the slides, I think a lot of the improvement in healthcare that we have seen, be it in renal transplantation, the capacity to be able to do coronary angios and angioplasty, all of it has been in the private sector. And the reality is that the private sector goes wherever the funds are. Nobody will go and put a unit up in a part of the country where you wouldn't have citizens that have the capacity to be able to fund that level of care. So that is why you'll find that things seem to be skewed towards the southwest, but particularly Lagos and Abuja, where you have a concentration of the more wealthy populace in the country.
The other question was regarding the cost of transplantation, because obviously there is a cost of dialysis, but is the cost of transplantation so high that even if you are paying for dialysis for a year, you cannot afford a transplant?
Well, the problem with paying for transplantation is that you have to come up with the funds all at once, as opposed to what happens with dialysis, which you pay for each time you come. So even if over the 1 year, the total cost of your having twice or thrice weekly dialysis, along with investigations and drugs, including the erythropoietin, would be more than the cost of a transplant, because you have the leeway to do it weekly. You're better able to afford that than looking for the lump sum that you require if you're going to do a transplant.
Thank you. I think John has his hands up. John?
Yes, I have a question. Thinking of Ghana, it was often the case that a transplant could happen because of the company the person worked for, or slightly surprising to me was that the local church was paying for it. Now, when I came to Nigeria, I'd forgotten to mention this in my introduction, Edwin, but I should have done, because you invited me to a church service. I was very impressed. It was it's a massive church, absolutely packed. And when the proceedings started, you didn't just have one preacher. There was a series of various people with various roles. And if halfway through you thought you might leave, you couldn't possibly leave. It was packed. Now, there have been, certainly in Ghana, and I'm sure in Nigeria, funding from churches. What's that like these days? Are there enough people to contribute to one of their parishioners?
it's a pity I actually left out that slide, which looked at total transplants and where the funding for each one of those transplants have come. Quite a number of them have been self-funded, but quite a number also appeal to the public. So almost every day in the papers, on the radio, in television, you'll find people making appeal. And even these days, GoFundMe's are being put in place for individuals asking for assistance towards the transplant. But you're right as well. The Lagos state government, which is the state political leadership in the place where we practice, have actually funded about 15 of our transplants. People go to the state government and they say, okay, we'll sponsor it, and they give them funds towards the actual transplant. And yes, there have been several churches. There's a popular church here that we've done about 20 transplants for.
Right.
They go, they appeal to the head of the church, and he actually, both for ministers, I've done about 3 of their ministers, and for members of the congregation, they actually do go ahead and pay.
Yeah.
People appeal, and generally people in this part of the world tend to be quite generous with assistance. But then you're talking in terms of funds in excess of, in Naira terms, about 8 to 9 million Naira. So you find people have to appeal to several people to be able to get the funds to do it. The other bit to that is that, yes, people then go out, obtain funds for the transplant, and forget that post-transplant, you still need to fund regular follow-up and the immunosuppressives, which are equally just as expensive. So that also now becomes a problem, and quite a few of the transplant failures that we've seen have been consequent on that. Individuals who had a successful transplant but could no longer afford regular use of the immunosuppressives, and then the kidneys eventually fail.
Well, that's very, yeah, can I just follow that up slightly? Where do you get your drugs from? Is there a system? I mean, the Indian manufacturers, aren't they the cheapest option and just as reliable, etc.? Where are or are the drugs just an ad hoc according to which person's buying them? There's no system, perhaps.
Well, most of the pharmaceutical firms are represented here in Nigeria. So we get your TAC and cyclosporin from, Sandoz, or the Cellcept from Roche. But true enough, and it's interesting that you say that, because you find that when we buy the drugs through those official channels, they are sometimes 2 to 3 times more expensive than those who get it through from India, even the very same drugs. And I think it's because India has been able to negotiate, I think based on the huge numbers that they have, significant enough discounts such that if you buy them from them directly, you get them at a fraction of how much you get if you get them from Basel in Switzerland.
Thank you, Chairman. Thanks very much. Thank you, David.
Thank you, Ebun. Can I ask one more question about the cost of post-transplant medication? So compared to dialysis, which you said it was $136 per session, how much would the transplant medicines cost for a month or for a year? Will it be in thousands?
Yes, it's the equivalent of about 150.
Sorry, I think we lost you for a little bit. Sorry. Ebun, I think we lost you for a little bit. Right. While we are waiting for him, John, did you have any other comments?
No, but I mean, I do remember one of the NANs, the Nigerian Association of Nephrology meetings, where somebody put a slide up, very bravely really, of a vast number of people who'd been put on dialysis. Oops, dialysis. Can you hear me still?
Yes.
Yeah, been put on dialysis. I mean, several hundred. And at the end of the year, almost all of them were dead. And somebody said, well, what was the cause of death? They said, well, renal failure from running out of money. And that made the audience just think, my God, you know, I mean, it's pretty terrible. So dialysis is very much a second player, isn't it, in this whole activity?
Yeah, I can't agree with you more. But since we lost Ebun, I think we should bring this meeting to an end. But it was quite amazing, and I'm sure Joyce will get in touch with Ebun and convey our thanks. But thank you very much, everybody. Meet next week.
Thank you.